I'm really pleased to see so many people here, and especially a lot of people whose faces are not familiar, so that's great. We do have a sign-in sheet that is going around, and so we're interested to know who is here and have the opportunity to invite you to future seminars. During the academic year, our program sponsors a seminar approximately every month. We may have a bit of a hiatus over the summer, but stay tuned and hope you can come in the future. Today, I'm really pleased to be able to introduce someone I've known for quite a while. We were just realizing we've known each other for about 20 years. I first met Renee Johnson when she came as an undergraduate from Spelman to a summer program at the University of North Carolina, where I was teaching at the time. She did such a fabulous job in her summer program that we recruited her into our MPH program and then to stay on into our doctoral program. So she finished her doctorate at University of North Carolina in health behavior and health education in 2004, went on from there to do a postdoc with the injury program at Harvard, and then took a faculty job at Boston University, and 2 years ago moved to Johns Hopkins, where she's now assistant professor in their Department of Mental Health, and also serves as deputy director of their drug dependency epidemiology training program. I hope I didn't blow up that name. Her research interests cover a variety of topics in risk behaviors related to substance abuse and various types of violence, as well as issues particular to specific vulnerable populations, people of color, LGBT youth, immigrants, and people in low-income environments. Today, she's going to be talking to us about its relationship to some of the social and injury and violence problems that we need to be paying attention to, particularly given where we are located. Yes?
It may just be me, but I'm having difficulty hearing you. Could you maybe?
Yes,
yeah.
I'm having difficulty too.
Okay. Our AV guy hopefully will fix us.
Thank you.
So I'm glad we didn't miss anything too terribly. That makes life easier.
FYI, personal microphones are made for men because they wear business suits. Okay. Can you hear me now?
It's a little low, but clear.
And we are recording, so okay. Renee, when you do take questions, please repeat the question so it comes through on the recording.
Okay, great. Thank you. Thank you very much, Carol, for that introduction. How many of you here are focused on injury research? Okay, great. So I'm glad we've got a distribution. I had dreams of doing a presentation on all of the injury problems and all of their relationships and their relationship with marijuana. But then once I got through marijuana policy and how we got to where we are, I was already at like 60 slides. So I'm going to talk about injury just a little bit at the end. But what I really will talk about is marijuana policy from the 70s up till now, and what's happening at the federal level, what's happening at the state level, and then I will think a little bit and talk a little bit about how this might impact use, particularly among adolescents. So Carol introduced my background, and I just wanted to really quickly say I come from an injury background. I'm not classically trained in substance use epidemiology, which I think gives me a great perspective for studying substance use because I didn't grow up in that field. So my first job was at Carroll's Injury Prevention Research Center at UNC in North Carolina, studying child homicide. And then I went on to do my doctoral work at UNC in the master's and doctoral program. After that, I went to Harvard and studied injury there. And so at this time, I just thought, I studied violent injury, and I thought I was a pretty I knew what I was talking about. I understood the problems of low-income urban environments. And then I went to BU, and this was the first time I was not affiliated with an injury center, and I was faced with having to find my own funding. And if you're an injury, then you know that that's difficult because there's no center that, exclusively funds injuries. So my chair at the time, who studied cancer, said, well, find a topic and find an institute and marry your interests. And I thought, alcohol and injury, people have done that forever. I'll just choose marijuana. And at that point, it wasn't nearly as big a deal as it is now. So over the 4 years that I've had this Career Development Award from NIDA, the field of marijuana research has really exploded, and it's been an interesting time. And after getting that Career Development Award, and if any of you are interested in Career Development Awards, I can talk to you about the process of getting one. I went to Hopkins, and that's where I am now. So, okay, so the lesson and the reason why I've spent a little bit of time introducing myself in this way is because if you're in injury and violence and you don't know about drug policy, you might be missing something. And I say that because I thought I knew about urban neighborhoods, and I was missing a big piece of it. And I'm actually grateful in a way that there's no funding for injury, because it made me study a different topic and then made me deepen my thoughts about injury and violence. Okay, so I'm just going to jump right in and talk about marijuana policy. As we all know, marijuana is illegal at the federal level, and it has been so since 1937 as part of the Marijuana Tax Act. Throughout the 1900s, up until the 70s, U.S. drug policy was a patchwork quilt of different things. There was pharmaceutical policy and narcotics policy and then marijuana policy, and then the Controlled Substances Act of 1970 really reorganized all drug policy and established the scheduling system, which I think everybody knows about. So as part of that, so it was a really important act. Marijuana was then classified as a Schedule I substance, and that means there's no currently accepted medical use, and it's among the most dangerous drugs with a high potential for severe psychological or physical dependence. This status is controversial and has been contested many times, but it hasn't yet changed, and who knows if it will change. So that's what happened under Nixon, and it was a big deal. It really reorganized drug policy. And then under Ford, he didn't do much in terms of drug policy, but he did put drug prevention education under the Department of Education. I'm going to talk about Reagan in a minute, and drug policy really changed in the 80s. But Carter was the last time that people really, until now, that people talked about marijuana in the way that he's talking about it. So he actually campaigned on this idea of decriminalizing marijuana, which once you hear about Reagan, you'll realize how different that was. And his quote was, or what he said was, penalties against possession of a drug should not be more damaging to an individual than use of the drug itself, which hints at what later became a big kind of slogan for marijuana legalization advocates, which is that incarceration or arrests are worse than the effects of using the drugs. Okay, so drug policy during the Reagan administration, and it's interesting to read all of this as a scholar, because this is when I was growing up, and I realized I grew up in an era with the most intense drug prevention education ever. So in 1982, that was his first term, and he declared a war on drugs. He didn't do a ton about it. In 1986, he redoubled support for war on drugs and passed the Anti-Drug Abuse Acts of 1986 and 1988. This really changed the landscape of drug policy. They established harsh criminal penalties for drug use. And the U.S. policy was that everyone who uses drugs should face a criminal justice contact. Before then, it was high-level offenders, kingpins, things like that. But now it was mid and low-level offenders, not traffickers, but just people using the drug. So, and that led to record high increases in stops, searches, and arrests. The ADAs also established mandatory minimums, which were a pretty big deal, and this actually increases people's sentences, and it really takes power away from judges. I don't know if any of you are lawyers in the room, but people get a lot of training to kind of decide how to sentence a case. And all of that training and all of their discretion just goes out the window with a mandatory minimum rule, because they've got to do whatever the law says. So federal policy became very punitive, and states followed suit so as to get federal grants, or federal grant money. So for the first time, the police got tons of money. I think it's something like a 1,400% increase in the amount of money that local police departments get. So for the first time, local police departments have SWAT teams and military equipment to focus on drugs. So what was happening culturally also matters. There was a real attitude in the 80s of stigmatizing drug use. And the crack epidemic was happening, and this was incredibly devastating, particularly in low-income communities. Along with that, it was in the paper every day. A New York Times editor said, well, yeah, maybe we did go a little nuts talking about the crack epidemic. So it was terrible, but it was also highly sensationalized and kind of used to pass some of these punitive drug policies. There was also an increased acceptance of a criminal justice approach to social problems. Before the 80s, the idea of incarceration was dying out. It wasn't something, criminologists, sociologists, this wasn't the direction we were going in, and everything kind of changed. And drug use and healthful living was seen as a matter of willpower and personal responsibility. And many of you will remember Just Say No as a giant campaign. That was the First Lady Nancy Reagan's platform. So it's important to recognize that punitive drug policy was not a Republican thing or a Democratic thing. Everybody was on board. The Anti-Drug Abuse Acts passed with very little. I think maybe 6 members of the Congressional Black Caucus voted against them. Everybody else was on board. And these policies became institutionalized over time. They were strengthened under Bush. He added some amendments to the Anti-Drug Abuse Acts. Under Clinton and Bush 43. And they're usually put in crime bills or welfare reform. So they would add amendments like you can't have public housing or public assistance if you had a drug offense. So I've said the term war on drugs, and it's just worth defining that. It's a pejorative term, really, used to describe the set of policies focused on addressing drug use via the use of punitive criminal sanctions. It started out as a federal government initiative to reduce drug use, and then kind of became pejorative over time. Okay, so what was the impact of anti-drug abuse acts and this how we treated drug abuse in the 80s? You see what's happening here. This is a really difficult graph to look at when you think about the difficulties of being in prison. So you see in the mid-80s this giant slope in the incarcerated population. The National Science Foundation had a book on incarceration and said that the growth in incarceration rates is historically unprecedented and internationally unique. So there are profound and disturbing racial disparities in who's in prison. This slide is 10 years old, but the kind of disparities are still in place. So 1 in 3 black men will be imprisoned in a lifetime. So there's definitely racial, ethnic, and gender disparities in who's incarcerated. So what are the impacts of drug policy on criminal justice populations? Currently, 1 in 110 Americans are in correctional facilities. 1 in 35 Americans are under correctional control, meaning incarcerated or under parole or on probation. And as I said, there are profound racial disparities in searches, arrests, prosecution, and sentencing. There are 1.2 million drug arrests every year, and about 43% are for marijuana possession. So each year, about 500,000 people are arrested for marijuana possession. Blacks are 3.7 times more likely than whites to be arrested for marijuana possession, despite similar rates of use. And so if you think, well, maybe it's just because of buying or things like that, everybody who's using marijuana got it illegally. So there's similar rates of use, similar rates of drug crime, and disparate rates of arrests. People have looked into why there are differences in the rate of arrests, and one is high surveillance in low-income urban neighborhoods. And part of this is to prevent violence. So police are in low-income urban neighborhoods. People in low-income urban neighborhoods are more likely to buy or sell drugs outdoors versus indoors. And so criminologists have looked at, what proportion does this explain? What proportion does police bias explain? And there's a lot of research going. What concerns me as a public health person is that we talk a lot in public health about health disparities, but we don't recognize the contribution of incarceration and arrests and drug policy to health disparities. So why would a criminal justice contact contribute to disparities? A criminal record is a terrible thing to have. You lose voting rights, you lose financial aid eligibility, making it difficult to ever go to school unless you stumble onto thousands and thousands of dollars. You become ineligible for job opportunities. You become ineligible for public assistance and access to housing. So you can't go to school, you can't vote. It's difficult to get a job. It's difficult to get public assistance if you don't have a job and you have nowhere to live. And these are coded into law. It's not just that people who run public housing facilities decided this. It's a structural thing. It also contributes to family problems. It's very difficult to adopt a child if you have a drug offense. It's very easy to lose custody of your child. It's traumatic for children who have parents in prison or who have seen parents be arrested. It contributes to marital dissolution and other relationship problems. It's also expensive, and this is a population who doesn't have a ton of money to start out with, but there are lawyers' fees, court costs, lost work time, restitution. So it ends up being very expensive. And then just thinking about mental health psychologically, it's hard to overestimate the psychological damage from a drug charge. So I'm going to spend some time on this slide because it's important to me, and I hope you will find it important as well. There's this term, mass incarceration, and it's used to define this concept, what we have going on in America, extremely high rates of incarceration in the U.S., particularly among black men from low-income urban neighborhoods. So legalization advocates will say legalizing marijuana will end mass incarceration. And then researchers, economists, prohibition advocates, and others will say the role of marijuana offenses in mass incarceration is largely exaggerated. So this first statement is an overstatement. And the second statement, I think, is an understatement, and it doesn't acknowledge, even if it's 200,000 people a year being arrested, that's still a terrible, terrible thing that is possibly not consistent with our values. So it really doesn't recognize the devastation of an arrest. So, and I've heard people say that at conferences, and think it gets us off the hook for dealing in public health with mass incarceration. So my statement is, while legalizing marijuana is not the answer to mass incarceration, punitive drug policy is part of a social system that subscribes to mass incarceration. So we're part of this system, and addressing drug policy is important. So my vision is that we in public health have a sustained commitment to development, enforcement, and evaluation of drug policy and crime policy with a focus on and a commitment to racial justice. I hope that's where we go moving forward. So that's federal policy, and I'll come back to it in a little bit, but I'll move to state policies. And I should start out by saying these are all misnomers. Like, there's no legal marijuana. Decriminalization, it's still a crime. Medical marijuana, I mean, what do we consider medical? But we'll use these terms. And I'll talk about these three classes of laws, and then I won't talk about local governments, but local governments have their own ordinances, so it's even more complex. So, medical marijuana laws. The HIV epidemic and other circumstances focused on chronic diseases led to advocacy for medical marijuana. So in 1996, California passed Prop 215, which was the first medical marijuana law in the country. As of 2015, 34 states have passed medical marijuana. This doesn't mean that it's legal, but what it does mean is that persons are protected from criminal penalties for medical use, and that there's some medical oversight. And what that medical oversight is depends on where you live. Some common qualifying conditions are cancer, glaucoma, epilepsy, and seizures, which you see on CNN a lot, HIV infection, and pain. 23 states have comprehensive laws, and this means that the state has some arrangement for obtaining marijuana, such as home cultivation or dispensaries. And also means that multiple strains are permitted. So some states just have, you can only have high CBD marijuana. And then there's decriminalization. 19 states and the District of Columbia have decriminalization laws. 9 were passed in the late 1970s, and that's that Jimmy Carter era. That was very brief. And then the remainder since 2001. What this means is that penalties for use or possession do not include jail or prison time for first offenses. It's usually limited to small amounts, like 1 or 2 ounces, in some places as high as 8 ounces. And the sanctions include a civil fine of a couple $100, an educational program, losing your driver's license for minors, or nothing at all. It's important to remember that decriminalization laws don't take the jail time out of a marijuana offense. Subsequent offenses can be severe. Did I put this in here? I have a hidden slide, but the AAP came out in support of decriminalization, and I wrote a letter to them because they said, nobody should have we're not about giving criminal records to people. But when we looked at all of the laws in Minnesota, you can have 1.5 ounces of marijuana and not have any jail time. You have 1.6 ounces and you can be in jail for up to 5 years. So decriminalization, what it means is very different based on the state. And then there's actual legalization laws. 4 states, obviously, you all know this, you live it, it's probably on the news every day. And the District of Columbia have legal marijuana laws, and many other states have ballot initiatives pending. So everything will probably change in the next 6 months. What this means is that there are no civil or criminal sanctions for recreational use or possession for adults 21 and older. Again, this is limited. There are penalties for going above the limit. The amount is usually 1 to 2 ounces, sometimes as high as 8 ounces. I think that's Alaska. Some states allow home cultivation, usually in about 3 to 6 plants, and some states tax and license the product. But in all states, public consumption is a civil offense. So the things that I think it seems that we all agree on is legal marijuana should be restricted to 21 and older, and we should really not have any public consumption. So what I think is happening is that there's a cultural shift. We went through this punitive drug policy period, and now we're in another period. Richard Bonney, who used to be at NDCP, calls this the collapse of prohibition. And others have talked about an end to the war on drugs. So Gil Kurlikowski, who used to be director of ONDCP, stopped using the term war on drugs. He said it was counterproductive. And then a couple years later, ONDCP said, we can't arrest our way out of this problem. So this new era that we're in, we're really realizing that we need other ways to focus on drug use. Obama passed the Fair Sentencing Act of 2010, which includes reform of mandatory minimum sentences, which I don't entirely understand, but it seems like there are still mandatory minimums, but judges have discretion as to whether they want to use them. So it's not mandatory, I guess. And then there are lots of support for alternatives to incarceration, such as drug court and community corrections. So I think one of the real damaging things about punitive drug policy is that you don't see people who use drugs as people, and there's this stigmatizing of people, addicts, dirty for people who use drugs. And the new drug czar, Botticelli, wrote this great article that was really focused on reducing the stigmatization people who use substances or have substance use disorders face. And this was in Huffington Post, so I encourage you to Google it. And I'm the deputy director of a training program, and we looked at this and we all made a commitment to talk about drug use in a way that doesn't stigmatize people who use drugs. So he said, research shows that the language we use to describe this disease can either perpetuate or overcome stereotypes, prejudice, and lack of empathy that keep people from getting the treatment they need. So along with these cultural shifts is an increasing public support for legalizing marijuana use. Since 2013, more than half of Americans have said that they support legalizing marijuana. And this is all ages, but if you look, under 40, then it's even higher. So the trend is certainly toward legalizing marijuana use, or public support for legalizing marijuana use. So as I read all this and thought about the history, I just wondered, what led to changes in attitudes about marijuana policy? It's interesting. In a lot of ways, we're more conservative than ever. But in other ways, for example, with gay marriage and marijuana legalization, the country's really changing, and really changing quite quickly. So one was AIDS activism. I think people saw people in pain and didn't like the idea that they couldn't use a drug that they felt would make them better. There's also perceived hypocrisy. People have noted, particularly advocates, that alcohol and tobacco are legal and not scheduled, but have substantial harms. So, the idea is, why can't I use this drug that I like that actually doesn't, hurt me very much? It's not my voice. There's a human rights argument that criminal justice disparities adversely impact blacks and poor people. And then a growth in libertarian ethics, a belief in personal freedom and preferences. And I thought about your article when I was thinking about this, preferences, that part of how we change policy in this country is public support and what the public wants and sees as appropriate. And then there's also a rethinking of what law enforcement's priorities should be. There's a group, LEAP, Law Enforcement Against Prohibition, and they want law enforcement out of drugs, and their thinking is that they can do the job they're really charged with better if they don't have to arrest people. And I see that argument because from having a background in violence, people don't want to talk to the police if there's a murder, and part of it is because they've seen SWAT teams go into people's houses and they've seen people arrested. So there is an argument to be made that relationships with police could be improved in certain areas. And then finally, there are the financial arguments that a criminal justice approach is expensive, and economists have really, this is true, that jail is expensive, and that a lot of people are arrested, but most of those people are not charged, so you've just wasted a lot of time and money. And then resources to gain from regulation within a legal framework, for example, taxes. So I think those are the things that are happening, but possibly more. Okay, so now that I've talked a little bit about what happened, where have we been, I'd like to think a little bit about adolescent marijuana use. So substance use, and marijuana use in particular, is a pediatric issue. Most people start early in life. So 57% are going to start before age 18. So there's a reason to focus on young people. If you get to 25 and haven't used marijuana or haven't become a regular user of marijuana, you're probably never going to do so or develop a substance use disorder. These are data from the National Survey on Drug Use and Health, and alcohol and cigarette use have gone down significantly since 2002. Marijuana has gone down as well, but stayed a little bit more stable. And now, for the first time, we see marijuana being more prevalent than cigarette use. So then the question becomes, will adolescent marijuana use increase? And a lot of people say, not a lot of people, the minority of people in public health say no. Young people report easy access, even those who don't use marijuana. So 80%, more than 80% of high school seniors say that they could get marijuana if they wanted to. And nowhere near more than 80% are using marijuana, so that's an argument to consider. Other people have looked at changes in marijuana use following medical marijuana and decriminalization, and there hasn't been an increase. It will still be illegal for people younger than 21 years old. And diversion to adolescence is risky for businesses within a legal and regulated framework. On the other hand, people say, yes, of course it will increase. The prices are going to fall by 10 to 40% because it's easier to produce and distribute a legal versus an illegal product. Diversion to adolescence is likely, and we see that for alcohol, tobacco, and even medical marijuana. And legal status normalizes use and reduces risk perceptions. I thought thought about that last argument, and I thought, does the legal status normalize use, or does advertising normalize use? So I think there's some teasing apart that we can do between the two. But the bottom line is that the research is inconclusive and much more work is needed to kind of think, and we need to just keep looking at trends and adjusting our policies in relation. Also important is that how legalization is going to impact use depends on the regulatory regime. So pricing, taxation, corporate free speech versus advertising, these are things we are going to need to work out. And I think what we need to do is use the best lessons from alcohol and tobacco research, apply them to marijuana, and then also build our research in regulatory science related to marijuana. Okay, so 23% of high school students in the U.S. report past 30-day use, and 40% report lifetime use. These data are from Monitoring the Future, and they show past 12-month use since 1975. So what you'll see is that in the late 70s, more than 50%, or about 50% of high school seniors reported marijuana use. And that dropped through the early 90s, and then increased back by about the turn of the century, and has stayed stable since then. So the question I thought about was, how have patterns of marijuana use changed in the past 15 years? And I'm going to look at this time period right here. So I'm going to examine, I'll talk about this right now, examine past 15-year trends in lifetime prevalence of marijuana in comparison to other drugs. Past 15-year trends in marijuana use using multiple measures of use. Often we just use lifetime or past 30-day. And then look at subgroup analyses. So how is this different by race, ethnicity, sex, and race by sex? Data come from the CDC's Youth Risk Behavior Surveillance System, which is a school-based survey that generates nationally representative data about U.S. high school students. You here in Colorado do it, but you don't contribute to the national data. So if anybody has the power to do that, I would love to talk to you. I'm going to present national estimates of the percentage, and I don't present confidence intervals because it would be too many numbers to see in a PowerPoint presentation, but I have them if you are interested. And I do a trend analysis, so I'll help you interpret this. What a linear trend, if it's positive, means there is a consistent increase. And if it's negative, it means there was a consistent decrease. A quadratic trend means that there was a change in direction over the time period. So if it's positive, it means there was a decrease followed by an increase, or if it's negative, it means there was an increase followed by a decrease. And you'll see what I mean in just a second. So here is part of my first aim, which was, what's happening with marijuana? Is it different than other drugs? And most drugs throughout the time period showed a statistically significant linear decrease. So cigarettes went from 70%, wow, that's crazy to think that 70% of high school students were ever smoking cigarettes that much, but it's decreased to 41% in 2013. That's how you read it. And then this is the linear trend, negative 0.14, that shows that was a consistent decrease. So the trend for marijuana looks a little bit like the trend for hallucinogens, ecstasy, and cocaine, where it has decreased till about 2007 or 2009, and then a slight increase. So we may be at the beginning of an uptick, but it's not clear, and we need to continue to look at what's happening. So this is the second aim, where I looked at multiple measures of marijuana use. To not just look at one single measure. And they're all going down. Lifetime use has gone down since 1999. Repeated lifetime use has gone down. Past 30-day use has gone down. Frequent use has gone down, though not by very much. And then what was good news also was that the percentage who are using before age 13 has also gone down. And now if that had gone up, that would be something that we should think about closely, because if you use marijuana before age 13, you're substantially more likely to develop substance use disorder. So here is the national estimate of the percentage of past 30-day marijuana use among U.S. high school students by race or ethnicity. And if you just focus on the purple, you'll see that the highest rates of use are among American Indians, multiracial, and Native Hawaiian Pacific Islander youth. Asians have the lowest prevalence of use, and then blacks, Hispanics, and whites are the middle of the pack. How has this changed over the time period? For the most part, it's gone down. The magnitude by which it's gone down by group has differed. And for blacks and Asians, it hasn't gone down. It's actually gone up by a bit, and that's evidenced by a statistically significant quadratic trend. I'm going to come back to that in just a second. So these are sex differences, which are really interesting. Most groups have a statistically significant sex difference where males have a higher rate of use. But over the time period, this has gotten much smaller. For example, among American Indian Alaska Natives, the male excess, meaning how much higher the prevalence of use was for men versus, or girls, boys versus girls, was 33.3 percentage points. By 2013, that had decreased to 2. So whites, if you look here, their sex gap, I can't get it, has stayed pretty stable, from 6.7 in 1999 to 5.5. But Native Hawaiians and multiracial youth, now actually girls have a higher rate of use than boys. So when we think, this underscores the importance of doing sex by race and subgroup analyses. In 1999, the U.S. high school students, the black-white difference there was no difference. Blacks and whites were using at the same rate. By 2013, there was a 9% difference. And part of that, most of that is because the decline in use among girls was much slow, among black girls, was much slower than the decline in use among white girls. So in summary, use has decreased since 1999, and this was a period of a lot of policies, a lot of medical marijuana policies. It just made me think there's not as much cause for alarm as some people would have you think. And marijuana is not, different from the pack. It's decreasing along with other drugs. It was lowest in 2009, and there's been a modest increase since then. So we may be at the beginning of an uptick, but we need to continue to look at that. So other data systems, Monitoring the Future and NSDUH, saw a decrease in their 2014 data. So it looks like that it maybe wasn't an uptick, but rather just random variation. In terms of prevalence by race, it's highest among American Indian, Native Hawaiian, Pacific Islander, and multiracial youth, and the middle of the pack are black, white, and Hispanics, and their sex differences are decreasing for all race groups except for white and Asians. So I think it's important to refocus our energy on girls and think about what's happening with that population. So this was limited because the states that don't contribute to the national survey are Washington, Oregon, and Colorado, which also happen to be the states that passed legal marijuana. But none of that happened before 2013. So it probably won't be great to use this data set moving forward, but it works for this. So I just wanted to talk, I'm running out of time, about some prevention considerations. We need to focus on prevention. The policies are changing and we need to be on top of it. So one thing that's happening is that we're doing programs that work specifically for marijuana. And this is difficult because often people say alcohol, tobacco, and other illicit drugs. But people are now starting to say alcohol, tobacco, marijuana, and other illicit drugs. And even if they have been shown to work specifically for marijuana, we don't know that they'll work for marijuana within a legal framework. So lots of work needs to be done. I've been thinking a lot about communication of risks. How do we want youth to perceive the harms involved with marijuana use? How does this information combined with the perceived risks impact their use? And fear appeal and assessment of risks, how do we go about prevention? So when I was a young person, I literally had no idea of the differences across the different drugs. Like, I thought heroin was equal to cocaine, was equal to marijuana. And the percentage of young people who perceive harm in marijuana use is decreasing. And this is something that prevention folks are really concerned about. And I just think maybe it's not terrible. Maybe they're accurately perceiving the risks. And the good news is that the risks are declining, but that's not associated with increased use. They've always been connected, and now in the mid-decade, they kind of changed. So it's not as if people are just decreasing risks, perceptions, and increasing use. So I think young people have the internet, and they're like accurately, or not so much accurately, but they're seeing nuances in different drugs. Like, it makes me feel great that 63% of people think taking heroin once or twice is risking harm. And 13%, I don't know what I want that number to be, but it's worth thinking about. Second, I think we need strong theory in prevention. A lot of what happened in the 80s was people just assumed that adolescents were just being pressured to use drugs by their peers, and then said, just say no, peer pressure, blah, blah, blah. And it was so much more complicated than that. And what I think happened was people forgot about family influence. And how your parents talk to you about drugs and what their values are very, very important. And I hope that we think about how adolescents make decisions and include family in how we develop programs instead of just a limited view on peers. And then the messaging. For alcohol, the message is like, don't use it until you're 21 and then be responsible about it. And for tobacco, it's never use it, it's terrible, and associated with cancer. And we haven't figured out like which one is marijuana, or is it a third idea? So there's a lot. If you're in behavioral science and you're interested in marijuana, these are kind of fun things that you might want to look into. Okay, so as I said in the beginning, I was trained in injury and violence, and I think the people who are trained in injury and violence have a lot to offer this field of drug research, and I hope in the future we can build more bridges. One, injury people know policy analysis and know regulatory science. I feel like as an injury student, I was more advanced in those areas than many of my colleagues. Obviously, an expertise in traffic safety. I know Ashley and others study motor vehicle crashes, and that's going to be really important in the future. Injury people are good at surveillance and looking at emergency department visits and things like that. And also, we know violence, and at this point, we've all got to figure out, like, how is marijuana and use and policy related to different aspects of violence, youth violence, intimate partner violence, family violence. And it looks like it's different from alcohol, and that's nuanced, and those are things we have to look at. So I guess the lesson here I'm saying is injury and violence people have a lot to contribute to marijuana research. Okay, I'll stop there. Thank you so much.
We do have time for question and discussion.
Yes.
Can you tell us a little bit about how the restrictions from NIDA and the DEA on research has driven and affected public policy with respect to marijuana?
So it was how have restrictions on the federal government and NIDA have impacted marijuana research. So I think I can't talk about it a lot, but there are limitations. What did they say? NIDA's hand is tied in a lot of ways. I can't remember because I just heard Norville talk. So clinical trials are more difficult. You can't look at specific strains. You have to use this one specific strain. Obviously, you can't do policy advocacy, but that's not what scientists are really about anyway. So I think it impacts it a lot. I don't do the clinical and experimental research. It's really hard. So there are people at Hopkins who are doing the experimental research, but there are just lots of red tape and bureaucracy, and they use one strain, so the generalizability is limited. So rescheduling would change some of that.
So one of the things you had alluded to is sort of family values and influence there. Mm-hmm. I think that point should be made even stronger, because if you look at the trends of marijuana use, the dip and then the increase again, that absolutely follows parental behavior. So for parent, and it's applicable to cigarettes as well as to alcohol. If the parents condone or demonstrate acceptability of that drug use, the kids are going to use. I mean, we know that happens. And so that when we had that dip, the parents were sort of relative non-users, and now as we've seen that increase, the parents were users in the 70s and 80s of the teenagers. So I think the important message is that, and I do adolescent medicine and we counsel families all the time, is for parents need to absolutely role model behavior. And if a parent says, oh, you know what, don't use marijuana, that's a bad thing to do, but they're smoking their legal marijuana Thursday night, that's the mixed message. And the kids go the opposite way. And that's the issue with what we're doing in our state. We're condoning marijuana use, period. It's good for it's good because it's medically legal, and it's good because it's legal, period. So yes, 20 years from now, we're going to see that curve way up here.
Well, there's also a couple things. One is this idea of hypocrisy. So parents who smoked marijuana in the past but no longer do feel bad telling their kids don't smoke marijuana. And I think that's a real thing, and we as, smart theoreticians need to develop messages to say, if you used marijuana, this is how you talk. That doesn't mean you don't get to tell your kids you don't want them to use marijuana. You just need to say, I used it, don't use it. And the same thing happened with smokers, because people who smoked cigarettes didn't want their kids to be cigarette smokers. So some people had to come up with really good messaging that's like, I am a smoker, but I don't want you to be.
That's a challenge, and that's one I rarely encourage parents to lie.
Yeah.
But that's but if you, and this happens with all risk behaviors.
Yeah.
If you say, okay, yes, I made mistakes as a kid. I did coke. I did this. The kid hears it's okay to do that. They don't hear that next step because they've got that. Their executive function isn't there yet to take in those messages.
Yeah.
So it's a very complex thing in terms of what we're doing, in terms of role modeling behavior and demonstrating. So.
Yeah. There's so many hands you can go and then you.
I wanted to respond to this gentleman's comments. Adolescent medicine, you say? So, my comments are coming from the perspective of a parent. So I think there's a danger in anecdote, and I'm going to give you an anecdote. And there's a danger in generalizations. They're both evil. In reality, is somewhere in between. But just to present, anecdotes have power. I'm live in a upper middle class neighborhood. Have close friends across the street who are like us and have two kids like us. And I think my anecdote is that adolescence is very complex, and parenting is very complex, and kids are very complex. So my kids, to my knowledge, haven't used drugs. We have these friends across the street exactly like us. They're probably a little bit stricter in their parenting, and their kids are probably a little bit, we still look at them a little more docile. But I have two girls, and they have a boy and a girl. The boy is the younger of the two adolescents. They all go to the same high school. Marijuana is available. It's always been available, and legalizing it, may or may not have made it a little more available, but marijuana has been available in Colorado high schools, for decades. So that's not a problem. And these parents, model perfectly, as I think, in my household, we model perfectly. And their son, as perfectly as we can. Their son, has started using marijuana probably a couple of years ago. Parents have tried to be responsible in their approach, including bringing him to therapy and trying to get whatever help they could. And nothing has helped. I think, there's some hardwired stuff going on, and this kid is hell-bent on continuing to use marijuana despite a lot of things. And I have, a child who's not using drugs but is hardwired to have behavioral health issues, as all adolescents do. So I think, adolescence is a mystery to all of us. And I'm not an adolescent health specialist by any means. I am a physician by training, but not a pediatrician or an adolescent. Parenting has humbled me to realize the importance of adolescent mental health, the impotence we have to a large extent, and to not make generalizations, to not be holier than thou, and to realize that what we think is true probably isn't true, and it's adolescence is something to hope we all get past as parents and as kids. Like, we were all there, and I did stupid things. I rode in a car with a friend at 100 miles an hour because it was a thrill as an adolescent. I sure helped by the grace of God that my kids don't do that, and I survived that. But adolescence is sheer stupidity, sheer risk-taking, and a lot of hardwired stuff that we will never control. And we can talk all we want about it, but we really don't understand why this kid does great. My older daughter is a perfect model of whatever, and neighbor across the street is a big risk taker, and despite some similar environments.
I didn't do anything. It was perfect as an adolescent. But I'm kidding. Thank you. So I want to just take a couple questions, and then I'll answer as many as I can. So you had a question, and then you could have, and I'll just answer them.
So I'm actually a toxicologist. I have no idea how the behavior stuff really works.
Okay.
And so one of the things I was curious about was, do you have any evidence of what triggered the upswing in 2008? And it does have anything to do with routes of use, so edibles versus smoking. Okay. And then also, why do adolescents use? Has that changed over time?
Okay. And what's your question?
My question has to do with police interactions, because it's been a big issue about behavior of some police officers regarding individuals they're contacting and using violence against those individuals. And it's my understanding that a lot of those initial contacts are based upon possession of illicit substances.
Okay. And any other questions? Yes.
I'm wondering what the science is now saying about marijuana as a gateway drug, and if there's any validity in that.
Okay. Yes.
This is a bit of a follow-up question to hers. I was hoping that you could expand a little bit more on that analysis you did around the youth and high school user rates, to explain how that informs Colorado's work right now in marijuana. What are the main messages that we should really take to inform policy today?
Okay, awesome. All right, so what triggered the upswing in 2008? What I think happened is, in a given population, people are going to use drugs, and that is we got really low. And I think we just kind of hit the floor, and then it just went back up, and it could have been random variation, but I just don't know how much lower we're going to get.
Is it pictures of the president smoking? Of teenagers?
No, I really don't think so. I mean, I just think it went pretty low and had to kind of come back up. I don't think young people are using marijuana because the president used it. But I could be wrong. And then you talk about routes of administration. They are changing. I think there's more diversity in routes of administration. And that is an area where we need more science. I'm hoping to do some science. And for example, edibles, I think there may be an increase in use among adults because smoking is harsh, and if you're not a cigarette smoker, putting stuff into your body is not comfortable. Well, once you're over that barrier, then smoking's fine. But if there's this thing that you can use this drug without smoking, I think it'll change things. So police interactions and initial contacts, I think, Michelle Alexander has this concept of pretext stops, and I had never heard of that before, but I think there's a lot of pretext stops, meaning marijuana is the excuse for stopping people. And some justice said there's no drug exemption to the Fourth Amendment, meaning you can't just stop people. They're just using drugs as an excuse to over-survey low-income urban blacks. And it's a shame because I worked in Massachusetts trying to get a primary seatbelt law passed. Black people did not want that, and they're like, I don't want another reason for police to stop me. So actually, this actually impacted what could have been a really good public health law, and I can concede to that. And I also went to testimony at the Maryland State House, and they were talking about legalizing. There's no bill, but they were just talking about it. And some of the council people for Maryland said, or I don't know, they were some legislators, said, well, how will the police get people who they think are doing something bad if they don't have marijuana as an illegal thing to get them on? And I just thought, is that what policing is? So there's some things to be done around searches. And I think the negative aspect is it makes the relationship between people who live in a community and the police not good. And we want that to be a good relationship because we want the police to do their job and to prevent violence and to help young people and to be a safe place to go. But I think sometimes these pretext stops damage the relationship. Science and gateway. Oh my gosh, I could talk so much about the gateway drug. So most people who use marijuana will never go on to use another drug. Most people will never go on to use heroin or LSD. So the gateway theory it's flawed in a lot of ways. But yes, if you use LSD, you probably have used marijuana. So I don't think it's the strongest theory. I think there is something to be said and some research to be done around how you sequence your drug use. But so the traditional gateway is tobacco, alcohol, marijuana, hard drugs. Use is going down. Like people aren't using cigarettes, and it's certainly not like a gateway for alcohol like it used to be. And also there's evidence that, or I'm working on a paper that's looking at sequencing of drugs, and what we find is that blacks are more likely to use marijuana as a first drug than whites. So that traditional sequence they didn't do a subgroup analysis to really look at it. So I think gateway theory is a pretty thin theory. I think it's worth looking at sequencing of drugs as a way to understand how young people are using drugs and to better prevent them. But this idea that if you use marijuana, you'll then go on to LSD, I don't think is very helpful. And we care about marijuana use and preventing marijuana use, we care about preventing LSD use, but I just don't know how it helps. And it seems to be something that a lot of anti-marijuana advocates say a lot. And I just think, like, have you read the papers? Like, have you really thought that through? It's not helpful. So the analysis, so I just talked to Scott today, who is looking at the prevalence of use. Who asked that question? I'm looking. You. Yes, you used the prevalence question. So what I think this means is, let's keep monitoring adolescent marijuana use. Like, if it just starts to really increase in a way that is scary, then we need to really think about what's happening. We need to really think about what's happening. But this paper for me I did it because people kept talking about legalization. It's going to be terrible. What's going to happen? And all this medical marijuana, kids aren't going to know what's up and what's down. And alarm. And I think what's better than alarm is science and just looking at what's happening in a careful way. And so it looks like there was a little bit of an uptick, but it was pretty low. And a lot has happened, so you might expect an uptick. So we need to look at Colorado. I know Scott's working on Colorado and what's happened, and it looks like it has, and Ashley, and it looks like it has not increased. Washington, same story. So what I think it means is we need to continue to monitor. And if there's a cause for alarm, let's sound the cause for alarm. But if we, as public health people, are constantly like, the world will fall if marijuana is legalized, then when the world really is falling, nobody will listen because we sat there and said, you should be alarmed, you should be alarmed, you should be alarmed, constantly. So let's alarm people when it looks like I hope that makes sense.
Yeah.
Yes?
It may be somewhat related, but given that different states have really different regulatory schemes, is there one, I'll try to make it short, is there a regulatory scheme that you sort of like more than others?
Yeah, I don't do that. I'd have to think about that.
Okay.
Thank you.